Okay, it's 7 o'clock, and I'd like to start this webinar. So tonight, thank you for coming to our webinar, Unlock the Power of Medication Advisory Committees, or MACs, to drive safer, smarter aged care. My name is Chauncey. I am a program officer at Northwestern Melbourne Primary Health Network. I may have already spoken to some or many of you here. I am part of a team that reaches out to aged care homes in our catchment area. So there's around 131 of those homes, and we hope to be building staff capability and to keep visiting homes in person to speak to you about what your needs may be. So hopefully, if we haven't met yet, we will soon in the near future. Olivia has her camera off, but I'd also like to introduce her as back-end support. She's also a staff member with us with the primary healthcare team, working with GPs and anyone in the primary health sector. Before I begin, I would like to pay my respects and acknowledge the traditional custodians of the land on which our work, especially Northwestern Melbourne PHN, takes place, the Wurundjeri Woi-wurrung, the Boonwurrung, and the Wadawurrung people. We pay respects to elders, past and present, as well as pay any respects to any First Nations people in this session with us today. A few housekeeping tips and rules. Please keep your microphone on mute. Also, we do have the chat box functionality up today, so please ask questions through the chat box, and Olivia and I will be monitoring that throughout the session, and we will try to answer all the questions at the end of the presentation today. This session is being recorded. However, we will be doing breakout rooms, and we will pause recordings during those breakout rooms to ensure confidentiality and resume recording again. And also, very importantly, please ensure you are joining the session using the name you registered so we can mark your attendance and so you can receive your CPD points. If you are seeing that your name is not as you would like it to be to receive your CPD points, you can change your name on Zoom. So if you sort of go down to the bottom of the Zoom screen, there's a little icon that says participants. It's next to the chat box. Click on that participants icon, and you will see all the participants in this room right now. Find your name and hover your mouse over your name. There's going to be 3 dots, and when you click on that, you'll be able to change your name. If you need any help with that at all, please just pop it in the chat, and Olivia and I can help you with that. And lastly, before we get started, I can't really give like Amanda, Atish, and Brooke like the credit that they deserve, and like they're very uh, their breadth of experience, but just very briefly, it's not going to do them justice. Dr. Amanda Cross is a National Health and Medical Research Council Emerging Leader Research Fellow at the Center for Medicine Use and Safety at Monash University. And she has authored over 40 peer-reviewed publications and is also serves as a National Board Director for the Pharmaceutical Society of Australia. Dr. Atish Menek is an experienced and compassionate GP with over 15 years, starting in the UK's NHS before moving here to Monash University's Department of General Practice. And Ms. Brooke Blakely is a lecturer at Monash University Centre for Medicine, Use and Safety in Melbourne, and is also a registered pharmacist and a project manager for the Medical Research Future Fund. So please give them a round of applause in the chat function, or like if you would like to also introduce yourself, please do so using the chat function. You can just drop in your name, your background, and where you're dialing in from. With that, I would like to stop sharing my screen and pass this over to Dr. Amanda Cross.
Thanks so much, Chauncey. We'll just bring up the slides. Amazing. So yeah, welcome everyone to our session on unlocking the power of medication advisory committees. So hopefully we can give you some tips and tricks and also share some of our experience from individuals within our MegaMac project about the role of the MAC. Just the conflicts of interest. So a lot of the work we're presenting tonight and a lot of the lessons are from our MegaMac project, which is a Medical Research Future Fund or MRFF funded project. So Atish and I are both chief investigators on that project, and Brooke is our project manager. And then other conflicts. So I am a board director for the Pharmaceutical Society of Australia, but I'm not representing them tonight. And Atish is an owner and director of Aged Care GP, but is speaking as an individual tonight as well. The learning objectives, I guess, just to understand a little bit more about medication advisory committees, or MACs. We'll probably save most of the time tonight in terms of key strategies to establish and enhance your MAC and their role in sort of quality improvement. And we'll also touch on how on-site aged care pharmacists, or ACOPs, can sort of be more involved and support the MACs as well. So we have tried to make this a bit more interactive, so apologies if you turned up to just sit there and listen to us while you're eating your dinner, but we're hoping to engage you a bit more. So we have a couple of Slido questions. So if you scan the QR code with your phones, it'll bring up a couple of questions. So the first one's nice and easy. It's just yes or no, so don't have to get stressed by that. So the first question is just, have you attended a MAC meeting before? Just to get it, I guess, a little bit of lay of the land of our participants tonight. How are we going for numbers, Brooke? Do you want to show the, oh, we've got 11. Feel free to leave it open on your phone as well, because we'll ask a couple of subsequent questions through the session. Do you want to show us the results, Brooke?
I think so.
Okay, good. So we've got a bit of a mix from the keen beans that have done it. The QR code's still on the screen, Libby, so you can still scan that QR code that's on, to the left of the screen. There'll be a new question that pops up in a minute. But yeah, so we've got about 3/4 who have attended a MAC, and then about 1/4 that haven't, so that's great. And then the next question, what is a MAC? This is a test to see the 75% that have attended it, whether we know what a MAC is. So again, the QR code is still on the side of the slide there, so if you like, you can scan that again, but if you're already in it, it will have already popped up with that question, and this is a free text, so feel free to tell us what you think a MAC is, and it's not sponsored by McDonald's. More than just the definition, I guess, what do you see as a medication advisory committee? What is their role? What do you think they should be doing? What are they doing? Yeah, so we've got clinical governance, collaborative, oversight. Yep, so again, that's sort of thinking about that being at more of a systems level. Multidisciplinary, oh, we're all popping up now, great. Yep, so quality improvement, sort of advisory kind of committee, looking at sort of improving potential issues, discussing and improving, yep. I'll give it maybe one more minute, see if we can get some ideas flowing. So lots of that sort of systems level kind of oversight kind of ideas, advisory oversight, policy guidelines, AMS, antimicrobial stewardship, looking at medications and how to improve their use. So again, yeah, taking that step back from sort of resident level, but more looking at patterns of medication use across the entire home, discussing areas and yet whether they can lead to identifying quality improvement issues, audit and feedback. Yeah, we'll definitely touch on that today. Excellent. We might move on from there, Brooke, I think. QUM, yeah, quality use of medicines, good. And I'll hand over to Brooke for the next few slides.
Yeah, so there's some really great comments that came through in that word poll, I think. And I guess here in this slide, we're really providing that formal definition of a MAC. So it's been identified as a clinical governance strategy to really promote medication management and medication safety in residential aged care. And the Department of Health, Disability and Ageing defines a MAC as a multidisciplinary committee that provides overarching governance of medication management to ensure the judicious, appropriate, safe and quality use of medicines. So that's a very formal definition of what a MAC is. But Atish and Amanda, I'd love to hear your perspectives on this. Perhaps maybe starting with Atish, from your perspective, what do you think a MAC is?
So I think MAC serves the functions as you've already described, but it also brings the team together and an opportunity that actually we don't have as GPs to meet the leadership team and work out what's going on kind of in the environment that you're working in. So I think there is something to be said for that opportunity to build those relationships and build those networks as well.
Yeah, absolutely. Thank you, Atish. And Amanda?
Yeah, I think I agree. I think we're all so busy racing from one thing to the other, actually taking the opportunity to step back and say, okay, what could be improved or what are the patterns here, rather than that sort of a day-to-day kind of work. We kind of do need to take a breath, take a step back and see what quality improvement we can do. And as Atish mentioned, it's that opportunity to bring different ideas and different perspectives all together to sort of come up with the best solution.
Yeah, fantastic. Some really great opportunities for the MAC. So on this slide here, thinking about some previous work of MACs. So MACs aren't a new thing. They've existed for over 25 years, but interestingly, there's been limited research into their structure and function. So we've summarised some of the key research on the slide here. So starting back in 2004, MACs were identified as a key strategy to support implementation of best practice. And then fast forward to 2017, MACs were identified as a key intervention to manage polypharmacy at that systems level of the MAC. Then in 2020, there was a study exploring the structure and function of MACs in the state of Victoria, and it made recommendations on optimising the structure and function of MACs too. And then in 2022, the Department of Health, Disability and Ageing published the updating guiding principles for medication management in residential aged care facilities, or the guiding principles. And this included a supplement called the User Guide, Role of a Medication Advisory Committee, or the MAC User Guide. And it also included an audit tool called the Audit Tool and Checklist for a MAC as well. And then most recently, we've got November 2025, where the strengthened aged care standards will come into effect, which make recommendations about clinical governance as well. So focusing on the national guidance about MACs in the last couple of years, the MAC User Guide really supports residential aged care homes to implement a new MAC or optimise their existing MAC. And then we have the audit tool as well, which was designed to support self-reflection to identify opportunities for improvement for the MAC. And most recently, as we just mentioned before, we've got the strengthened aged care quality standards in Outcome 5.1, which states that there should be clinical governance in place to actively manage and improve the safety and quality of care that our residents receive. So focusing back on that MAC user guide, it details 4 functions of the MAC. So those 4 functions are policy development, risk management, education, and quality improvement, things like going beyond that data, identifying, developing, evaluating and monitoring quality improvement activities at the local MAC level. So I'll leave this now to Amanda to go back to our Slido question.
Yep. So we've kind of given you the broad definitions and some of the resources that are out there, but what does your MAC meeting focus on normally? So again, it should have popped up if you already had the Slido open, or you can rescan that QR code as well. Quality indicators, yep. Infection rate. So I think, yeah, antimicrobial use and infection rates are very common. Medication errors, I think that's probably the #1 thing that I hear from different medication advisory committee members. And yeah, medication incidents or medication errors, yeah. What else have we got coming up? Quality improvement more generally, polypharmacy, yep. So could potentially be the National Quality Improvement Indicator, but also looking more deeply into that rather than just the NQIP indicator. medication errors and how they can be prevented. Excellent. Not just looking at the errors, but actually taking that next step on how we can improve and prevent them. That's great. So we've got optimizing compliance and standards. Yep. So obviously, probably the focus of a lot of MAC meetings at the moment with the new strength and aged care standards coming in soon. Benchmarking. Yep. Excellent. So again, sort of looking at that data and in the context of perhaps other similar homes or the national averages. Psychotropic use is very topical over the last few years. Obviously, there's the National Quality Indicator on antipsychotics, but psychotropic use more generally is definitely important to discuss. But a couple of people still typing, so we won't go on just yet. Policy changes, yep. Collaboration and communication. So perhaps opportunities to improve communication strategies across the home, that sort of thing. And whether those gaps in communication might be leading to incidents. Restrictive practices, yeah. So both chemical and physical restrictive practices, but obviously at a medication advisory committee, particularly the psychotropic uses, chemical restraint is often quite topical. All right, I think we've got one person last typing, so I'll let them type. All right, we might move on from that one. So we also were quite interested in sort of how medication advisory committees across the country were sort of structured and also functioning. So that audit tool and checklist that Brooke mentioned before, we actually used that to perform a national audit of medication advisory committees around the country. And this figure is representing the sort of main or key results from the 120 MACs that we actually audited. And those 120 MACs looked after about 650 sort of aged care homes, which was about a quarter of all the aged care homes. So it's a good cross-section of it, but obviously recognising that they had to have a medication advisory committee to do the survey. And we do know anecdotally that a number of homes don't have one, or perhaps don't have one that they may want to report on. So some of these results are probably a little optimistic compared to what might actually be the averages. But I guess just to highlight some of the things on this figure, and it is published if you wanted to look more into this, and we might send it around for the Northwest Melbourne PHN to circulate with the slides at the end as well. But the MAC structure, so the left-hand side of the figure, about half the MACs were chaired by registered nurses, so those internal staff members typically. Just over half were multidisciplinary, and we've got the next slide, we'll sort of go through that in more detail. Most of the MACs reported they occurred quarterly, so that is as the recommended frequency. And most of them sort of had either face-to-face or hybrid, so they weren't all purely online generally. There's different sort of structures in terms of whether a medication advisory committee might look after just, for example, one residential care home, or perhaps a medication advisory committee looks after a couple of and sort of oversees a couple of residential care homes. But the median number in this study was 1, but it did range up to 70. So there are some organisations which have sort of an organisational wide kind of medication advisory committee structure as well. And then the functions, so the 4 core functions which Brooke mentioned, we'll go through those in the subsequent slides in a little bit more detail. So in terms of the structure, the membership, so the most common memberships that were reported across the 120 MACs that did the audit were the medication review pharmacists, so residential medication management review pharmacists, and the registered nurses, as well as senior management and community pharmacists, and then the GPs were generally present, and then just over half of them. So the next 4 slides will go through the 4 core roles that Brooke mentioned. So, and these are as per the user guide and the audit tool and checklist. So role 1 is to develop and endorse policies, procedures, and guidelines, and advise on legislation and standards. So those topics came through in your earlier questions. So it's great to see some MACs are doing this. According to our audit, we had about 78% that reported that they did have a role in developing and endorsing policies, procedures, and guidelines, which is really exciting. Recognising that a number of organisations may have individual specific teams or members that might develop some of those guidelines, it's really still important that the medication advisory committees are able to sort of provide insights or help endorse, or at least be aware of those sort of new guidelines and procedures that are coming out. And One key thing which is possibly an opportunity to improve is having that communication strategy. So when new documents or guidelines or procedures are released within that aged care home or that aged care provider organisation, is having a really clear strategy for how they get communicated to all staff, whether they're internal staff or perhaps external contractors such as GPs or community pharmacists. The role 2 is to advise on risk management systems associated with medication management. So really encouragingly, nearly all our MACs reported that they did collaboratively develop strategies to control, reduce or eliminate medicines-related risk. And on the slide, you can see lots of the different types of information sources or data that they use to inform and update their risk assessment. Atish, I wonder, in the sort of MAC meetings that you've attended, what sort of data do you often discuss in your MAC meetings?
I think the most common, in all honesty, is infection rates in the MACs that I go to. That's a rolling data that's presented back and forth. I think this is a facility that traditionally had a lot of antimicrobial prescribing, so there's a focus for them, and that obviously then becomes a rolling agenda going forward. But it's interesting to see how trends are coming down now that we're all hopefully prescribing more appropriately as a result.
Yeah, excellent. And I guess hopefully with a greater spotlight on it, because it is being presented at the MAC, it's a bit more in front of mind. So yeah, I guess being able to track that data between meetings is really exciting as well, because you can see then hopefully the success of being able to discuss that and identify quality improvement strategies.
Yeah.
One other thing that was asked within this role was whether the MACs had reviewed the 2022 guiding principles for medication management in residential aged care facilities and whether they were adherent to them. And as you can see, there's potentially still a little bit of work to be done there. But yeah, it's still great that over half had reviewed and were adherent to them. I'm just reading the chat. Yeah, Neil, so yeah, there is a greater focus on adverse drug reaction reporting. So I think that's going to be a really key sort of data point to capture within that role 2 of the MAC. Capturing them in an important and sort of meaningful way as well. So if there are adverse events occurring, how we can perhaps better monitor signs and symptoms to prevent them, to be a bit more proactive. Within role 3, so role 3 is identify education and training needs for medication management. So again, this was 93% of the MACs reported that they did support provision and access to education and training on medication management. So I think this is really great. Obviously some aged care homes have dedicated individuals or dedicated teams that do sort of deliver education, but I think it's really important that the MAC is able to sort of feed into that, perhaps about, you know, if there is a pattern of, for example, high antimicrobial use, then that leads into perhaps we need a greater education about when that might be needed. Same with sort of restrictive practice that came up in sort of one of the ideas that were someone mentioned before. Again, if you're seeing a higher use of psychotropics, perhaps there needs to be a greater education in terms of when a psychotropic may or may not be indicated. And I think that sort of lends on to when we asked about whether the MACs had a role in assessing competency and training needs to then inform that education, the percentage was lower. So again, only about 58%. So if you are sort of identifying quality improvement areas, have a think about where that education could be supplementing that to sort of support that change in practice. And most of the education these days, I think there's still a huge role for face-to-face education, actually getting people engaged and interactive and answering those sort of things. But it's not the only way to deliver it. And sometimes education, I'm just reading Neil's comment, sometimes I think the old days where we had a PowerPoint and like everyone turned up in a room and just sat through that education is probably well and truly past. I think now that sort of one-on-one education and that sort of real capacity building and sort of micro coaching almost is taking off. And I think the aged care on-site pharmacist role can really support that as well. Role 4, so the structure and function within the structure and function of MACs. The role 4 is to monitor effectiveness and performance as well as implement quality improvement strategies for medication management. So 95.8% of MACs reported they were proactive and responsive to medication management issues. And I think that's come out from sort of the Slido questions where, you know, we're identifying the types of things that we should be monitoring. But identification, I guess, is the first step. and sort of developing that clear plan on how we can respond, and sort of that more comprehensive quality improvement plan could still be improved. So I think that's something particularly we've been very interested in. It's something that within the MegaMac project, which we'll discuss soon, has been a real front of mind for that. And I guess the other part within role 4, which is of interest and is sort of becoming more apparent, is the only 47% of MACs reported that they measure and improve individuals' experiences with medication management. So there's a greater opportunity to sort of integrate that resident or family feedback as well. So back to a Slido question. We've told you sort of what a MAC does and what the roles are by the book, but what actually makes a MAC successful? So what have you experienced in the past? What do you wish you would have experienced to sort of help make that MAC really successful? Yep. Got to have the right people in the room. Geriatricians, yep. GPs, nurse practitioners, pharmacists, nurses, we all need to be represented in order to get all the diverse perspectives. Support from the facility manager and RN, yep. Identifying who you need support from the aged care home is really critical. It might be, so obviously the local level, but you might, as we mentioned, might also need sort of engagement from education or quality improvement teams. Committee member engagement, yep. So having not just people on chairs, even if it's virtual chairs, but actually having them very engaged in the meetings. Having regular meetings, yeah. So some homes do prefer it more regular than quarterly. I have seen that. But action in gaps, I think taking action from the meeting, so it's not just let's discuss it and then let's discuss it again 3 months later, I think it's really important. And that, yeah, again, that active participation again, so you're really wanting people to be engaged and participating. The agenda and audit and feedback, music to Brooke's ears, she'll touch on those soon. And being organised and clear agenda, yeah, excellent. I'll hand it to you, Brooke.
Thank you. I think there's some really great comments that were mentioned there in the word cloud, and really things that we're going to see in this slide as well. So a lot of repeating, but it's really great to see that coming through already in your experiences. So on this slide, we've included some practical steps and tips that can help give the MAC the sort of strong foundation in the structure and function. So really starting with those meeting papers. So MAC members can review the terms of reference document, and most MACs generally have their terms of reference, but it can be helpful to review this yearly. And this ensures that it has, the terms of reference includes a clear purpose for the MAC, who the MAC reports to, and also that the MAC has got the right members so it can make decisions and implement them efficiently. And it's good to review the agenda, as was mentioned already before by you all. It's including its standing agenda items, but also being able to have opportunity for new business. So if there's any issues that arise, there's opportunity within the MAC to be able to discuss them. So just having a look at those terms of reference in the agenda, it's just everyone is very busy in aged care. So when MAC members are very clear on why the MAC is meeting and why it's important, this can really support the MAC's success. And building on that terms of reference, it's also really important to think about who the MAC members are. So the MAC user guide makes recommendations on who these MAC members should be, including, as it was mentioned before, multidisciplinary clinical representation to ensure all perspectives are heard during the MAC meeting, and also that there's management too who can provide organisational support and support in implementing decisions that the MAC might make. And as we see there about the chair, there's some different opinions on who the MAC chair should be. This could be perhaps an independent chair who can provide an external or maybe even an independent objective view on things, or whether it could be also an internal staff member. So this is something that really can be discussed at your MAC to work through what really works for your MAC and the homes that the MAC governs. And lastly, we've got in that second section there, the size of the MAC. So while it's really good to get as many perspectives as possible, sometimes it can slow decision making down a little bit. So discuss with your MAC on what you think the right number of MAC members are. So want to get enough so that there are those perspectives being heard, but then not too many that, you know, it makes decision making and running the MAC challenging. So could also consider, for example, some have discussed rotating MAC members. So this can be an opportunity for people to get experience around clinical governance, but also can help the MAC to hear new ideas and different perspectives as well. And then lastly, it's also really important to have good communication, as was mentioned earlier in the slide before in the Slido. And this includes identifying a suitable meeting format. For example, some find that a hybrid approach is really helpful, that helps able to get those external healthcare professionals who might struggle to get on site to be able to attend MAC meetings still. And it also includes things like circulating documents early. So MAC members then have enough time to read through the meeting papers so that the MAC meeting can really focus on discussion and decision making. And then lastly, closing the loop on the meeting. So this can be circulating minutes, documenting action items, and then also closing the loop on those discussions. So as Amanda said, not just waiting till 3-6 months later, but closing those loop on those discussions early. So we recognise that not one MAC or home is all the same. So really being able to work with your MAC and your home to be able to identify what's best for you at the local level. And we saw there in that word cloud, a lot of you have discussed, is a lot of data. We saw with antimicrobials, psychotropics, and there are a lot of data that the home collects, including our mandatory data, so NQIP and other data sources that we've discussed earlier. So a lot of time's invested into this data collection, and the MAC is really a great opportunity to use this data to drive quality improvement, looking at what's working, what maybe there's opportunities for improvement, so that there can be that development, evaluation, and also monitoring of quality improvement activities. So in addition to the data that the home already collects, there may also be other opportunities to use other indicators available to the MAC. So one example, we've got other Mega MAC indicators, and these were developed by New South Wales Therapeutic Advisory Group, or New South Wales TAG, along with Monash University as part of the Mega MAC project. So the Mega MAC indicators assess concordance with the guiding principles, so were developed or published, by the Department of Health, Disability and Ageing in 2022. So the Mega MAC indicators are split into 4 domains, and they assess the 4 overarching medication management processes as described as well in the guiding principles. So the first one looks at the MAC meeting. So it's assessing the presence of processes that promote good governance of medication-related activities at the MAC. Domain 2 looks at the policies, procedures and guidelines available to your home. So not just the availability of those policies, procedures and guidelines, but also ensuring that those guidelines are up to date. So staff have access to up-to-date best evidence available to them. Domain 3 looks at the home's admission processes. So it's assessing the presence of processes that promote quality use of medicines for newly admitted residents, both respite residents and also those who are permanent at the home. And lastly, looking at the medication review processes. So it's assessing the provision of comprehensive medication reviews, for example, like RMMRs, for residents at the home, but not just everyone, also those who are at high risk of medication-related harm. For example, newly admitted residents, residents with polypharmacy, and those who are receiving an antipsychotic. So these Mega MAC indicators come along with a suite of resources. So we've got indicator specification documents that support data collectors to find the right information and how to answer the indicator questions. And then we have the Mega MAC data collection tools. So these have really a twofold purpose. One, they help the data collectors to collect the data, but they also are really helpful for the MAC. They provide a visualization of the home's progress over time, able for the MAC to then sit and identify what's working really well at the home with their systems and processes, and then where there's opportunities for improvement. So an opportunity to identify goals for improvement, develop a quality improvement initiative, evaluate it, and monitor the progress over time. And we've got an example here on the slide of the data collection tool 1. So this is about the MAC meetings, the Mega MAC Indicator 1, and really an opportunity to be able to see that graph there to show what's working well with the MAC, where can we improve, and really drive that quality improvement. These are already published on the New South Wales TAG website and also on the Monash University website. So we've got the QR code there on the slide. So please feel free to be able to access that using the QR code as well. And lastly, just touching on the agenda items, I'll briefly mention this because this was covered very well with your Slido answers previously. But considering some agenda items that are relevant or topical can really help generate buy-in from your MAC members. So things that are really topical or relevant at the moment could be the strength and aged care quality standards that are generating a lot of discussion. And then also the monitoring of higher risk medicine use at the home. So as has been mentioned previously, this could be around the psychotropic use or antimicrobials as well. So now we come to the very interactive section of our webinar. So we've got a case study to consider together, and then we'll have the team will kindly put us into breakout rooms where we can discuss this outside of the recording, and then we'll be able to come back after 10 minutes and then discuss our distance together. So I might briefly just read this case study, and then this will set us up to be able to have a chat about it in the breakout rooms. So your residential aged care homes MAC meets quarterly and presents data around medication incidents and national quality indicators. Despite this, it's a challenge to encourage multidisciplinary MAC meeting attendance. So external healthcare professionals such as the GP and community pharmacist report that MAC meetings are very administrative and not clinical. They feel it's easier to just read the minutes when they have time rather than attending an in-person MAC meeting. So a key question to start off the discussion is, what steps could be made to improve multidisciplinary MAC meeting attendance? So I might stop the share now and then allow Chauncey to be able to put us in some breakout rooms to discuss that case a bit further.
All right, I can still see a few people that haven't joined their breakout room. You should have your invite on the screen. Can you please join it? Hi, Naomi. I popped you to breakout room as well. But if you're not keen to join, then that's fine.
Sorry, Olivia, I've just got my kids in the background, so yeah, I won't join.
No, you're right.
All
Switching
right,
out.
oh my gosh, I can't tell you. All right, so I'll just listen in if that's okay. Thanks.
Yeah, all good.
Thank you.
Hopefully we don't lose people between breakout rooms and coming back to the main room. Are you able to share the slides again, perhaps, Brooke?
Absolutely. I think our numbers are looking pretty steady, so hopefully we haven't lost too many.
It's always a risk when people accidentally leave the meeting and not the breakout room.
Yeah, it's always a bit challenging. It's the same button.
Yeah. All right. So hopefully you had a good opportunity to sort of speak in a less formal way and without the recording in case you know, scared to ask a crazy question, that sort of thing. I guess we've just got a couple of sort of high level points, which hopefully you sort of touched on during your meeting, sort of the breakout room. So yeah, the first one is to really establish a clear structure for your MAC, including sort of a terms of reference. And that should include sort of having conversations about who should be on your MAC, who should chair the MAC, what the ideal duration is, and how that meeting might look, whether it's face-to-face once a year, like that sort of thing. And the time of day or the day of the week when that MAC should meet to sort of optimize attendance. We had some really good ideas in terms of the duration. We had a bit of conversation about the duration, whereas, you know, 1 hour might be sort of the maximum time you can get into people's diaries, but it is quite hard to get through everything in 1 hour. So that's sort of a conversation that you need to have with the different MAC members. And in terms of when's convenient, again, it generally aligns with the schedules, most commonly of the GP, sort of came out from our discussions. Brooke, did anything else come out from you in your discussions in that slide?
Yeah, so we also had some good discussions around when the MAC should meet. So perhaps if that's later in the day, so again, around where perhaps the GP's availability, so whether that could be in the morning or later in the day, and then also the opportunity to be able to perhaps have some incentives like sharing some food, having some food at the MAC, so having, some lunch or maybe perhaps even an early morning breakfast. So some other little practical ways to encourage attendance. Yeah.
Excellent. Atish, any tips from you as our GP to get a good time when the GPs can attend?
I don't think there is a good time of day for us to attend, but maybe I'll focus on the positive bits of our little group.
Yep.
That's all right. So a couple of things. So planning at the start of the year for the entire year, so get it in the diary early. Avoid busy parts of the day, so not the morning meds round. And one really good suggestion from one of our colleagues was finding something valuable for the various members of the MDT. So, for example, our community pharmacy rep in our room talked about finding value in discussing kind of the medication areas that they could then speak to develop the policies in the meeting itself. So just finding something that targets all the MDT members.
Yeah, excellent. Which leads us on very nicely to the next slide, which is about getting the agenda right. So yeah, having an agenda that engages those MAC members really well. Similar to what you said, Atish, we had someone mention that they have like a GP update section. So then the GPs have a section where they know that they need to speak and they can prepare for that, and that sort of helps to engage them and get their buy-in. But also just ensuring not just GPs, but any of the visiting healthcare professionals gaining their input on the agenda to again sort of ensure their buy-in within that conversation and within that meeting. Brooke, anything else from your discussion on the agenda?
Yeah, similar comments around ensuring the agenda is clinical and it is engaging for all MAC members and it's relevant to them. And we had some comments around when discussing data at the MAC meeting. So not just looking at data in isolation, for example, just that quarter's data, but also looking at data over time. So being able to see a trend in the data, see where the MAC is going, and that can really help drive quality improvements. That's something that came up from our discussions.
Yeah. And we also had discussed sort of structuring the agenda so that if people did need to leave at the sort of 1 hour mark, for example, if the GP sort of had 1 hour time, that you sort of ensure that the things that they need to be there for are sort of packed at the start of the meeting. Atish, any other comments on the agenda from your room?
No, I think you've covered it very well.
Yeah. And then I guess the other side we had was just to, sort of getting the right people in the room. So sort of engaging with experts from your organization. We had a member that sort of had managed to get their quality coordinator and the education coordinator there, which was really important to sort of progress those conversations. So if you did sort of identify the need for an education to perhaps reduce a certain medication error or something like that, that you've then got the right person there to continue those that action item from the meeting. Brooke, any other thoughts on that one?
Yeah, we had an option as well that was discussed, perhaps about including a keynote speaker to attend the MAC meeting. This could really help if it's an area that's quite topical or relevant to the home at that point. That could really engage MAC members and really support buy-in as well.
Yeah. And Atish, I know we've previously discussed sort of how having opportunities for the GPs to review their prescribing data can then be used for CPD hours. I don't know if that came up in your room at all.
Didn't, but for any GPs in attendance today, that it's probably good Royal College fodder for your self-reporting. So hopefully helps convincing you to attend.
Thanks, Satish. So the last little section is sort of on the role of the aged care on-site pharmacist. So I know we've got a couple on the call today, but also a lot of the homes have recently sort of started with an aged care on-site pharmacist or sort of actively considering it as well. And a lot of the medication advisory committee and the quality improvement work aligns very closely with the ACOP role. So on the screen there, you can see the sort of 5 key areas of activities for the aged care on-site pharmacist, and the sort of 2 ones at the bottom of that figure is clinical governance, to advise, attend and report to the MAC, and quality use of medicine. So all these sort of activities we've described today could be sort of really strengthened by that sort of aged care on-site pharmacist as well. Some of the work we've been doing in the MegaMac project, but also in the Embrace project, if you're interested in any of that, is looking at that sort of systems level role for healthcare professionals, particularly pharmacists. So something that we've been looking at is how healthcare professionals can work as knowledge brokers to support the implementation of new guidelines or evidence or standards or whatever it might be, that sometimes can sit on the shelf and perhaps not get integrated into routine care or routine practices that quickly. And so the knowledge broker concept is sort of, a framework of how you can work at that systems level to support that implementation of evidence or knowledge. So acting as a knowledge manager, linkage agent and capacity builder. And that the aged care on-site pharmacists, particularly those system level roles, so that quality improvement, medication advisory committees and the quality use of medicines aligns quite closely to aged care on-site pharmacists acting as knowledge brokers. But all MAC members, obviously got to focus on the ACOPs in this slide, but all MAC members really should be sort of motivating and engaging other MAC members to sort of be in attendance and be engaged and be prepared and sort of having that robust conversation. I think the aged care on-site pharmacists, particularly if they're on-site and sort of having a leading role in the MAC, can support getting the right data ready for those meetings and making sure that they are across that data and ready to answer any questions and sort of support the development of quality improvement initiatives that may come from that MAC meeting. Again, they may be well placed to conduct audits. We obviously mentioned the MegaMac indicators, but there's a number of other indicators and also locally driven needs that may sort of prioritize certain audits of certain medication classes or certain practices, whether it's inhaler use or anything like that can sort of come from your MAC meetings and may be able to be facilitated by the aged care on-site pharmacists sort of taking a lead in developing, implementing, evaluating those sort of locally driven quality improvement initiatives. One thing in terms of pharmacists acting as knowledge brokers, so our MegaMac trial, which has recently sort of finished, we're currently analysing the results. We did look at pharmacists and MAC representatives acting as knowledge brokers to support the implementation of the guiding principles for medication management in residential aged care facilities. So these pharmacists weren't they weren't employed as ACOPs, but they had sort of dedicated protected time to focus just on this sort of system level role in terms of using quality indicators to identify areas of potential improvement and then designing and implementing and evaluating those sort of quality improvement initiatives. So the protocol for this is published, but we'll be analysing and presenting those results in sort of coming months as well. And I guess from that trial, we also did find a number of sort of opportunities for potential aged care on-site pharmacists as well. So driven from our experience and sort of the feedback that we got through that trial, I think there's a lot of opportunities for the aged care on-site pharmacists to support both their own MAC, but also support sharing of ideas between our medication advisory committees. So in our Mega MAC trial, we had a national quality improvement collaborative, which allowed for sharing between the different aged care homes that were involved in that trial. And that was a really great opportunity to share, strategies, or even just share, this is happening to me as well. It's not just me that's experiencing this. Can we come up with a better idea together? Or, I've tried that. Have you tried that? I noticed in the chat before there was a question about has anyone got experience with having consumer representative on the MAC? That was one of the things that was really trialed through the Mega MAC project. So a number of different homes that were involved in that project did trial different strategies for that, including having representatives on the MAC, having sort of a very clear two-way communication between, for example, their resident and family meeting and their MAC meeting, or sort of integrating additional opportunities for feedback through, for example, case conferences. And then they collated that feedback and presented that at the MAC meeting to sort of identify resident or family-led quality improvement ideas. I think the ACOPS, there's an opportunity for the aged care on-site pharmacists to engage internal stakeholders a lot more than perhaps pharmacists have had the opportunity to in the past. And particularly through sort of the Mega MAC project, we found there was a lot more opportunities to sort of, clean up how they were sort of analysing certain data or collecting NQIP results, or in our Embrace project, we found opportunities to sort of embed additional tools, the sort of latest evidence into information technology sort of supports, so that was there at that point of care. So again, opportunities for the aged care on-site pharmacists to be a bit more engaged in that sort of thing. Opportunity to lead quality improvement initiatives, which I think a lot of the pharmacists that I've spoken to that have come into this role are really excited by that opportunity to have a bit more time on site and a bit more a higher level of engagement with the aged care home staff to be able to lead some of those initiatives that they've really wanted to sort of get into, which is exciting. I sort of touched on the resident and family input already, but also I think as we are getting more aged care on-site pharmacists working in residential care home, I think I'd really encourage everyone to sort of network with each other. So again, we're not reinventing the wheel at every home, but there's really that opportunity to share ideas between aged care on-site pharmacists and sort of have that support structure as well. So that is the end of our slides. I guess in just a brief conclusion, MACs are an important clinical governance tool. Try not to just have them as a tick box that you have to do every quarter, to really try and see how we can improve them and how you can get them to work the best for your home to support quality improvement and quality use of medicines. We can't tell you the golden formula, unfortunately. I wish we could, but you really need to make sure that that is tailored to address the local needs and priorities and interests of your home and of your MAC members. I think from our research and from our conversations that we've had with lots of MACs across the country, there really is a scope for improvement. And I think there's a real role for the MACs, particularly as with the implementation of the strengthened aged care standards and the processes that are going to come along with that. Real scope for MACs to improve over the coming months and then lead into the next few years as well. And hopefully, if you haven't yet, you are sort of considering that aged care on-site pharmacist and how they could potentially be placed to act as a knowledge broker and sort of proactively drive medication safety initiatives in conjunction with your medication advisory committee. And I'll hand over to Chauncey to do some of her slides, and then we'll take some questions.
Thanks, Amanda. So before we jump into the Q&A with our panelists, I would just like to very quickly, I know your time is precious, talk about health pathways and why that's very important and related to your work. I'd like to start out by introducing health pathways to those who might not be familiar with it. And it's a very interesting cohort of people that we have here in this meeting, because health pathways started out as a diagnostic and referral tool for GPs only, but over the past years, it has been broadening out to include folks working in allied health, for example, to also use health pathways, some social care work, and most importantly, those working in RCHs and also pharmacists. So if you don't have access to Health Pathways, we strongly recommend you to contact us and we can help get you set up with a login account. And I can do that in a few slides from now. I'll just walk through a little bit more about what Health Pathways can do for you. It provides clinicians with a single website to access comprehensive collection of locally relevant clinical information and guidelines. And it's a handy tool for nurses working in residential aged care. As you can see on the screen, there are pathways for older adults' health, cognitive impairment, and dementia, including medication use in older adults. And there are pathways for RACH-related care in all different stages of the journey, entering, before entering, during, and transfer of care. It's designed to help nurses give consistent and evidence-based care to their residents and clients, and it also designed to support visiting general GPs and giving the best care. So here we have another example of what you can see through the pathways once you have a login and can access these resources. There's the pathways are set up so that, it starts out as usual with a broader section, and then you can go into more details as in, especially with like the topic today and deprescribing medications for dementia and antidepressants in older people, for example. There's also a lot of relevant resources on Health Pathways that is just like a database for you to access, just links for you to click on that is relevant to our catchment area. So I guess for every PHN catchment area, there will be like a general Health Pathways that everyone can see, but for metropolitan Melbourne, for example, there are localized referral pathways and specific information and also resources there. And also, you do get CPD points for learning and continuing to use Health Pathways. So please, if you have any questions about earning CPD points from this, please shoot our team an email. And this is how you do it. You can register via the QR link, and I think that goes to the registration site. But if you have any questions at all, please jot down that email address and we will get you set up. Thank you so much, and we are ready for Q&A. Let me just stop sharing for a moment so we can see each other if anyone does want to come off mute or turn on their camera. I can start with the questions that have already popped into the chat.
I think I've addressed everything that's come through on the chat as I've gone.
Okay. Yeah. This is really your chance to really ask some really detailed questions. Does anyone else have any questions they would like to ask? Okay, that's okay. Let me put up the conclusion slide. And so if you do have questions, we can have some contact information about where you can pass those questions to. So thank you for attending the session. We value your feedback, and your feedback does help us improve and change how we present our education to you. So please scan the QR code to provide that feedback to us. You will receive an email within a week, and that will include slides and resources and the recordings. You will receive your certificate within 4 to 6 weeks, and CPD hours will be uploaded within 30 days. So please visit our website to look at all the events and education that we have. And yes, please reach out if you have any questions about
there's a question that's just come through on the chat.
Great. Okay.
I don't know whether you want to ask it in person, in terms of what does the on-site pharmacist model look like? Did you want in terms of how many hours they do or what they do or what? what would you like to know?
That was my question. Now, I've heard a bit about the on-site pharmacist model, and I think the pharmacist who's doing the RMMRs at the aged care facility that I work is interested in that as well. But in practice, do people have experience already with an on-site pharmacist, and how does that work?
Don't want to throw you on Neil, but I don't know if you're still there, just because I know you are there. If you want to say anything.
Yes, I am here. It's a significant improvement on the RMMRQ program. I'm at my site 3 days a week. I'm involved with running the MAC. I mean, they hadn't had a MAC for about 12 months, so I'm making sure we have it every 3 months. I'm getting to know the residents much better. So previously I was doing a lot of RMMRs in a dozen different facilities, trying to understand a dozen different policies and procedures. I'm finding this much easier to get my head around now. I'm finding it much more rewarding. Hopefully, and I think the home is finding it much more rewarding from their perspective, and also from the resident perspective as well. I'm not restricted with when I can do the medication reviews. So when a problem arises, I can do a medication review then and there. I don't need to get a referral from the GP. And I've got better working relationship with all the GPs now. Not that I didn't have a good relationship before, but it's much deeper now. I do a clinical round once a week. I'm writing all the medication policies and procedures because they all needed updating, reflecting the new strengthened aged care standards. So there are only positives for this role compared to the old role. Not that the old role was bad, but this is an improved role.
I can imagine that the implementation of the RMMR recommendation is probably better that way.
Yes, it is. And you can follow up much easier as well. You don't have to wait a certain time period to follow up on your recommendations. And, sometimes it takes a few visits to see someone before you can make a good recommendation. So I'm getting to know the residents and also their families much better and what their needs are as well. So I think there's only positives for it. Yeah.
I think that's what a lot of us are really excited about, being able to build that engagement more with the staff and the residents and their families, to have that really tailored, person-centered recommendations about the medication, but also for things like de-prescribing, which is what we often write in our medication review reports, that you'll actually be there to actually support that process, because often it is, we try a dose for a certain time, then we reassess, or then we go down the dose, and being able to be there on site and support that process and ensure that gets implemented in a safe and effective way is really exciting.
Yeah.
And I think, as Neil mentioned, at least from sort of the Embrace and MegaMac project, now our knowledge brokers weren't doing resident level services, but even just from a systems level, being able to integrate into that team and build those better relationships with the on-site staff as well as the GPs and community pharmacists, just sort of links that communication much better, and so that you're able to then have more tailored responses and tailored quality improvement initiatives, because you understand what everyone is sort of experiencing and why they may or may not be doing certain things.
Very good, thank you.
Any other questions from anyone about MACs or ACOPs? Tish, I know I know we've spoken about sort of your hopes for the ACOP model. You haven't sort of worked with any aged care on-site pharmacists at the moment, but have you sort of got any ideas about sort of potential opportunities for the aged care on-site pharmacists?
I'm very excited to have someone on site to support, especially the clinical round concept, Neil. I think that'd be amazing if I could get someone to support on that practical basis, and the sorts of things that we struggle with. And I often use my current RMMR pharmacist for kind of the medicines information queries or de-prescribing support. It'd be great to have someone on the ground that knows the local environment, knows the families, that can help us with those prescribing decisions. So yeah, I'm very excited. I'm itching to get to someone in disease.
And if I can add something else too, that there's two ways in which you can get funded for the ACOP role. I personally went for tier 2 because I wanted to be independent from the community pharmacy. That was just my thing. But I support the community pharmacy. So when I first went there, a lot of the DD orders were being written for 4 months, and we know you can't write DD orders for 4 months because the authority only goes for 2 weeks. So every Monday morning, one of my first jobs, which is quite mundane but really important, is just to let the doctors know which orders are going to expire in the next week. And so the doctors can then easily just update those orders. And we haven't really had too many problems. We had one problem when our doctor went away for 3 weeks and didn't do everything I told him to do. But we get through these things. So I've been able to support the pharmacy that way when they're having trouble getting scripts. I have that relationship perhaps with the prescribers a little bit better, and I can help them in that regard. And also just little things like denosumab injections being missed because they're 6 monthly, and the order comes up, they haven't got the stock, they have to get the stock in, the next day the order doesn't come up, so whatever happens, it gets missed. And so I've just got systems in place now to make sure that the stock is there when the order comes up. The doctors are informed that do they need to do calcium monitoring, things like that. It's, just to get systems in place, and it's been really useful being on site. I'm on site 3 days a week, so I'm really enjoying it. It's my semi-retirement. I nearly retired at the end of last year because I was getting a bit jaded with all the RMRs and no increased remuneration for the last 5 or 10 years, and it's been really fantastic for me personally.
I'm just reading Chauncey's comment. I was going to say, yeah, so there's there's two, Neil mentioned the tier 2 funding. So yeah, there's tier 1 funding, which is through the community pharmacy, or tier 2 funding, which goes through the aged care home. And yeah, if you are sort of really interested in ACOP and you're not really sure how to find a pharmacist, and you sort of had some of the conversations with your community pharmacy, that sort of thing, the PHN is definitely able to sort of support identifying someone in your local area or someone that might be interested. I don't know if you want to speak more to that, Chauncey, or not.
No, but that's what my team is here for. And even if it's just a question, we could help clarify that for you or find the right person to get the answer for that.
And I think, yeah, there's more pharmacists that are getting into this space now as well. So we're there was a bit of a roadblock in terms of we're not sure how to do it, or we're not sure what we're meant to be doing, but I think that's building momentum. So yeah, definitely reach out if you've got any questions, or you're sort of not sure whether it's right or how to do it or that sort of thing. There's definitely increasing knowledge and people to support.
I keep saying, at what time in your career do you get an opportunity to write your own job description? It's right now. Yeah, it's exciting time, but Neil and I might be slightly biased because Neil started as an ACOP and I'm due to start very soon. So we might be slightly biased, but it's a very exciting time, I think. If there's no other questions, we might stop it there, Chauncey, if that's okay with you.
That sounds good. You get 2 minutes back in your day.
Yeah.
Thank you so much, everyone, for being here. And please, if you have time, fill out the survey that Olivia just posted in the chat. Thank you so much.
Thanks, everyone. Thanks, Atish and Brooke.
Bye.